Welcome to the second of 4 installments in the Trends in Behavioral Health webinar series. Today's webinar is titled, How to Avoid Getting Wiped Out by the Wave of Commercial Payer Behavioral Health Audits, Medical Necessity and Waivers of Coinsurance and Deductibles. I'm pleased to welcome Paul Gilbert, a member of the firm in Epstein, Becker, Green's Healthcare and Life Sciences and Corporate Services practices. We're also joined by John Mills, a partner at Nelson Hardiman, focusing on regulatory compliance and litigation for healthcare providers. Before we begin the presentation, please note that today's webinar is being recorded and participant phone lines will be placed on mute throughout the program. You're welcome to submit questions directly to the presenters during and after the webinar. Their contact information will be displayed again at the end of the presentation. In 2 to 3 business days, Epstein, Becker, Green will email registrants a link to access a recording of today's program and PowerPoint materials. At this time, I'd like to turn the presentation over to John.
Thank you, David. Welcome, everyone. Thank you for tuning in today. Paul and I will be speaking about the wave of commercial payer audits that is occurring across the behavioral health industry, particularly with respect to the addiction treatment providers. I will start by briefly discussing why it is that addiction treatment providers are undergoing such a heavy surge of payer audits and investigations. And then I will explore in more depth the types of provider practices that are most likely to be pitfalls in the context of seeking commercial insurance reimbursement. I'm going to put particular emphasis on the widespread practice of out-of-network providers waiving or discounting their patients' cost-sharing obligations. I will then turn it over to Paul, and he will be providing some very useful best practices on how to minimize the risk of being the target of payer investigations, as well as tactics and strategies to survive the investigations if and when they do happen. Paul will then conclude our presentation by briefly discussing the importance of setting up a compliance program at your center, and he'll touch on the nuts and bolts of how to go about that process. We'll then be happy to take a few questions at the end. Next slide, please. Full disclaimer up front about me. I only represent healthcare providers. I don't represent any payers. So my experience in perspective in approaching the topic of commercial payer audits and investigations is shaped almost entirely from my experience in helping my clients respond to payer audits and investigations. I frequently help my clients challenge and appeal claim denials, and these days, more often than not, I'm helping them defend against payer demands for repayment of allegedly overpaid claims. I want to make that clear up front because I am somewhat biased in my perspective. I can't help but see these issues from the perspective of my providers. So with that said, what I think is happening right now is that payers are reacting to a massive uptick in the volume of claims for addiction treatment over the past 5 years or so. And they are making it a high priority to rein in their spending on addiction treatment. Just by way of a little bit of history, I'm sure all of you know, the addiction treatment industry began primarily as a cash-based business, and because it was a cash-pay business, there was very little oversight and regulation, certainly very little enforcement of existing laws, and it was somewhat of a Wild West attitude when it came to a lot of practices that the payers are now scrutinizing. In 2008, we had the Mental Health Parity in Addiction Equity Act. It's a federal statute, and that requires health plans to provide benefits for mental health in a manner that is no more restrictive than those provided for medical and surgical health. Then in 2010, the Affordable Care Act was passed, and that expanded the Mental Health Parity Act and essentially made mental health and in addiction treatment a minimum essential type of coverage that had to be required in plans that were sold through both employer-sponsored health plans as well as on the ACA marketplaces that states were setting up or that was being done by the federal government. And then, of course, we get to the present where we have the opioid epidemic. This is making, headline news every day. Just today, or actually it was yesterday, actually, the Senate sent a massive bipartisan bill tackling the opioid crisis to the president after passing legislation. And, despite how partisan things are these days, this legislation passed 98-1. So think about that. That's truly bipartisan. This is one of the few areas that we're seeing true bipartisanship. And regardless of whether we might all have lots to disagree about that particular legislation, it's just amazing that it's just an area that is getting so much support by both the federal and the state level. Next slide, please. So, due to this gold rush mentality, I believe there's a perception, both amongst payers and amongst providers themselves, and probably the public, that the addiction treatment industry is attracting lots of bad actors and fraudsters, people who are just in it for the profit, and people who are willing to prey on the vulnerability of the addicts and the desperation of their families. We've all seen the headlines and the exposés of patient brokering by addiction treatment centers and the marketers that are hired by those centers. So it's not surprising that the insurance companies are pushing back on this perception and are putting a lot of resources into their special investigation units to detect fraud and to weed out the bad actors. Every insurance company has a special investigation unit, a SIU, and if you receive a letter from a SIU department, that essentially means that there is some potential fraud that they're investigating. Doesn't necessarily mean that they only look for fraud. They also look for ways to recoup money, regardless of whether it's fraudulent or not. But it's certainly that's what they're set up to do, is to detect fraud. And the SIU units, they work very closely with law enforcement. In fact, I would venture to say that a lot of the people who are the personnel who make up these SIU units are former law enforcement, former investigators for law enforcement, and they bring that law enforcement background to their job working for the insurance companies. And so they won't hesitate. If they see something egregious happening, they will not hesitate to refer to state licensing agencies and prosecutors, and they will work very closely with those prosecutors to build a case against fraudsters and bad actors. On a state level, we're seeing a lot more enforcement of health insurance fraud laws or anti-fraud laws. Here in California, where I am, we've got Insurance Code Section 1871, and we're seeing, for the first time in a long time, we're seeing lawsuits being brought under this statute against providers, and they're targeting the addiction treatment industry in particular, and these are cases that are oftentimes being brought by whistleblowers, more often not a disgruntled employee, but they're taking their concerns to the Department of Insurance or the Attorney General, and they're basically spilling the beans, blowing the whistle, and this is leading to pretty aggressive lawsuits by the states. There's also a lot of pressure on legislators right now to tighten up the laws in this area, to pass specific legislation that's designed to target patient brokering practices and other type of kickbacks, things of that nature. And I don't want to get too much into that issue because Paul and my partner Harry Nelson put on an entire program about 2 weeks ago on that. But it's just something that to keep in mind, that these payer audits are occurring in that context of increased pressure on all levels to rein in some of the abuses and bad practices in the addiction treatment industry. And then, of course, what the SIU audits will usually do, if all they uncover is negligent practices, maybe sloppy documentation, things of that nature, all of which we'll talk about in more depth, but at a minimum, they may not try to refer it to a prosecutor, they may not file a lawsuit alleging insurance fraud, but at a minimum, what they will do is they will seek, they'll allege an overpayment and seek recoupment of what they've already paid to the provider. And we're seeing, a wave of these right now. I mean, it's every single payer is on the warpath trying to recoup money that they've paid going back to, 3-4 years in some cases. And this is going to be a big deal. I mean, I've got plenty of clients who are getting letters from different payers saying, we want every single penny that we paid you going back to 2014. We want it all back. If our clients, they just ignore that, I mean, they're putting themselves at risk of a lawsuit. But certainly at a minimum, if they ignore it, they're going to end up being essentially blacklisted and not being able to provide, well, not being able to get paid for services provided to those insurance companies' members going forward. And we'll talk about that a little more as well. But there are also, in addition to these issues of fraud, I personally believe there's a desire on the part of the commercial insurance industry to reduce the number of out-of-network addiction treatment providers. And I say that because over the years, I've worked with a lot of out-of-network providers in different spaces. For example, I've done a lot of work with outpatient surgery centers, and we saw a massive uptick of new centers popping up all over the place 15, 20 years ago, and they experienced the same or very similar wave of audits and SIU investigations that the addiction treatment providers are now experiencing. And, when I talk to people and who do a lot of work with surgery centers now, everybody, at least here in California, everybody's saying the same thing. They're saying, yeah, the out-of-network thing is really just dried up. There's very few standalone out-of-network centers out there. Most of them have had to consolidate with larger healthcare systems or have gone in network and are surviving in network but aren't getting necessarily the same kind of profits that they were before. So that may be a long-term trend for out-of-network providers in the addiction treatment industry. It's maybe a little too soon to say that, but my sense is that part of what's motivating this surge of payer audits is really kind of a desire on the part of the payers to kind of clean house and really, only the strong will survive kind of thing. I mean, it's going to be sort of a type of evolution that, it remains to be seen what happens. But I think it's inevitable that we're going to see a significant reduction in the number of out-of-network centers out there. Paul, do you have any thoughts about that?
No, I agree. I share your perspective as counsel primarily to payers and those who are providers and those who are looking to invest in providers. While I think we may be a little jaded, I think we're also, your comments thus far have been accurate in terms of the perceived motivations of payers and the responsibility of providers to take steps to respond to those motivations and hopefully avoid, some of the consequences that can result from litigation or stopped payments.
Thank you. Next slide, please. So let's spend a few minutes talking about the common pitfalls for providers. I want to identify the areas and practices that are frequently the subject of payer audits and investigations. In other words, what is the low-hanging fruit for commercial payers when they are looking to deny claims or try to recoup money? Next slide. A big pitfall that we commonly see as lawyers is a lack of understanding on the part of providers when it comes to the structure of the private commercial health insurance system. And I don't have the time to get into this in any great depth, but the main thing I want to impart today is that there are different rules for different payers, and the most important thing to understand is that there is a federal law out there called ERISA, which essentially governs employer-sponsored health insurance plans. And most of the health plans out there, and I say most, I don't have a statistic for you, but most people get their insurance through their employer. But even when insurance is obtained through an employer, it could still be subject to state laws if it's a fully insured product. So if it's sold as a policy of indemnification, the way a car insurance policy or a home insurance policy is sold, then it's essentially governed by state law, because state laws are what the state law. The insurance law is a product of state law, and the feds have essentially backed off in trying to govern insurance law. Next slide, please. But when we're dealing with a policy that is a self-funded employer plan, then that really is truly a creature of federal law, meaning that if the employer is putting the money into the health care benefits, then what the employer is doing is they're hiring the insurance company to act as a third-party administrator or an administrative service organization. And they'll pay a fee to the insurance company to have access to that insurance company's network of providers, as well as to have the insurance company adjudicate and administer the claims. But ultimately, the dollars that are being spent on those claims is coming from the self-funded employer plan. And these types of plans are governed almost exclusively by ERISA. In fact, ERISA has a preemption provision that is very powerful, very wide-ranging, and it essentially overcomes any contrary state insurance laws. So it's important for providers to understand what type of plan they're dealing with up front. So when they're in the process of verifying benefits, it's worthwhile to do some homework and try to figure out where is this patient's insurance coming from? What kind of plan are we dealing with? Because that will then help you become educated on the types of laws that are at play and the types of rules that the insurance company or the plan may or may not have to abide by. Next slide, please. When we're talking about insurance company audits, I frequently get calls from my clients, and they say, hey, yeah, we got this letter requesting medical records. Do we have to comply with this? And my first question is, well, are you contracted or are you out of network? And if you're contracted, then it's a no-brainer. You absolutely must comply with it. You have no choice but to abide by the terms of your contract, and the contract, I can guarantee, gives the payer the right to conduct audits and request medical records. Now, certainly there is going to be contractual provisions that will likely dictate, how they can go about collecting records, and certainly you should be familiar with what those provisions are so that you can see if they're in any way exceeding what their contractual rights are. But, the first place to start, of course, is the contract. If you're an out-of-network provider, then it's a little bit different. It's less clear as to where the insurance company's rights to conduct audits really stem from. I think from the insurance company's perspective, their right's going to come from the fact that more likely than not, as an out-of-network provider, you've probably taken an assignment of benefits from the patient. And so once you have taken on that assignee status, you've essentially agreed to be subject to the insurance policy itself. At least that's the payer's perspective. And the insurance policy will give the insurance company the right to conduct audits and seek records. And so they will point to that document to say, this is what gives us the right to do this. There are various state laws out there that might explicitly give payers the right to conduct audits, so that's something to be aware of. And, I've had providers come back to me and say, well, we don't want to give the records to the insurance company because of HIPAA. We think that if we hand over all this patient information, then somehow we're violating HIPAA. And my response to that is no. The payers, if they're auditing, they want records regarding their own members, then they've got the right to get that. In fact, HIPAA probably has, I'm Paul may know this, but I'm pretty sure HIPAA has an explicit provision that gives them the right to request medical records of their own members when it concerns claim adjudication matters. So there's very little to be gained by refusing to cooperate with a payer audit. What happens if you just refuse to give the records, then they may not have a grounds to assert a overpayment because they don't necessarily know if they overpaid you without getting those records. But at a minimum, what they'll do is they'll say, all right, well, if you're not going to provide us the records, you're not going to comply with our request for an audit, then we are going to place you on we'll raise a flag on your tax ID number, and anytime you seek to get services authorized, that will be denied, and anytime that you submit any claims, they will be automatically denied. That's questionable whether that's permissible under either state or federal law, and I personally believe that there's some abuses on the part of the insurance companies when they put people on these no-fly lists, but that's what they're going to do, and so then you're left in the position of, if you want to continue treating those members, but you don't want to comply with the audit, then you have little choice but to file a lawsuit, and that, of course, gets very expensive, and then they will certainly get the records through the course of a lawsuit, through discovery. So it really doesn't make sense to refuse to provide the records. Next slide, please. Okay, let's talk quickly about practices that are commonly targeted in audits and investigations, and I'm going to go through these fairly quickly. So licensing certification, I put that up there because, at least here in California, the licensure of addiction treatment providers is sort of all over the place. It's very complicated, very convoluted. There are licenses for residential and detox, but then there's only certifications for outpatient, and now we have this new thing called incidental medical services, which requires its own form of licensure, and it can get pretty complicated in a hurry. And then there's different types of licensure for if you're providing treatment to adolescents, or if you're doing eating disorder eating disorder treatment. Is a whole other licensing scheme by different agencies. So it gets very complicated, and the insurance policies are written in a way that they define various terms. They define addiction treatment provider or addiction facility. They'll define the word provider, and sometimes these definitions in the insurance policies they don't jive with the reality of how licensure occurs in a particular state. And we've had problems with certain payers that are not based in California who are denying claims or refusing to give pre-authorizations on the grounds that they don't believe that the provider is licensed. And we go to great lengths to explain, no, they've got our clients have exactly the type of license that's available in California, and perhaps the type of license you're asking for, it just doesn't exist. It's not a question of our client didn't apply for license, they just couldn't because it didn't exist. So I'm just raising this because it's not as simple as like a hospital license, for example. It's a much more convoluted area that hopefully will gain some more consistency as time goes on, and we see just more state regulation of this industry. Another issue that's commonly looked at, in fact, probably the most commonly looked at issue, is documentation. I can't tell you how many times I've had provider clients who get dinged because of just really sloppy documentation. Just not, they might be doing everything right, but they're not writing it down. They're not documenting it. They're not getting somebody to sign those notes, or they're getting the wrong people to sign those notes. And when the records audit occurs, believe it or not, those records get poured over in great detail. A lot of these insurance companies, they will then send these records out to an outside reviewer who will spend a lot of time going over every single scrap of paper, and they will find any little thing they can to ding you on. If they see a missing signature, or if they think the notes look like they're kind of cloned, like it's the same note over and over and over again, so that there was not enough differentiation. That leads them to suspect that there was no real note taking, that it was just a form that was used. Or if you just rely solely on standing orders for some physician who's never even seen the patients, you know, is just stamping some standing order, that can be a problem. You know, maybe you're having face-to-face assessments with a physician prior to the admission into the program, but you're not documenting that, well, that's going to be a problem because most payers, under their guidelines, they want to see that face-to-face assessment. So documentation is probably if there's one takeaway, in my opinion, one takeaway from this entire program is to go back and make sure that your documentation practices are really airtight, and you know, put resources on that, put time on that, training your folks, because I can't tell you how easy it is for the insurance companies to claw back money on this ground of poor documentation, both at a medical necessity level as well as just, you know, showing that the level of care that you're billing at, that level of care was actually being provided. You know, keep in mind that the insurance companies have clinical guidelines, published clinical guidelines that they are going to expect providers to comply with. And, you know, again, we can argue, if you're an out-of-network provider, we can argue about whether or not you should be expected to comply with those guidelines. You don't have the ability to argue that if you're contracted, but certainly out-of-network, you could argue about it. But at the end of the day, those guidelines are out there, they're published, they're available on the insurance companies' websites, you could Google them, and they're pretty detailed, and you should take the time to familiarize yourself with them. And if your practices don't comport with those guidelines, then you need to think about changing your practices. You know, now, not every payer has exactly the same guidelines, and you know, it sometimes can be a challenge to try to comply with one payer's guidelines and at the same time comply with another payer's guidelines if they're conflicting. But I would say as a general matter, the guidelines are going to be typically more rigorous than, certainly more rigorous than any state law, state regulation, but probably more rigorous than the Joint Commission or the other accrediting bodies' guidelines. So it's worth your while to educate yourself on those guidelines. Another area that gets commonly targeted is billing discrepancies, and at the risk of stating the obvious, you know, don't upcode, don't miscode. You know, when you bill for a service, be sure that you're billing for exactly what was provided. Don't try to play games to try to, you know, jack up the reimbursement. The insurance companies, you know, they do these audits, they figure this stuff out. They know what games can be played, and they know how codes can be manipulated, and they will figure it out, and they'll demand their money back if that's what you were doing. And you know, part of what, and Paul will talk more about these types of issues, but you know, either have really good billers working in-house or work with a really reputable outside biller, because most of the billing problems we see, it's really because the billers are either don't know what they're doing or frankly are you know, not exactly you know, maybe not acting very ethical and not the best interest of their client. They're maybe working off a commission, so they are motivated to you know, to do things that will increase their own reimbursement. Next slide, please. Okay, I've got about. I'm going to try to wrap this up in about 4 minutes, so I'm going to fly through this next topic. I'm going to talk about the practice of waiving patient financial responsibility. You know, this is something that's been going on for years in the out-of-network industry, not just the addiction treatment providers, but frankly all out-of-network providers. Certainly the surgery centers have been doing this for a long time. So it's nothing new, but it's something that we keep on seeing. You know, I mean, I've spoken on this topic multiple times over the years, but I still see it. I still see providers coming to me saying that they've received a letter from a payer threatening to cut them off because they believe that the provider was engaged in fee forgiving or the practice of waiving co-pays and deductibles. And so this is something that if you're doing this or if you're inclined to do this, you need to understand why this is a problem and how to clean up this practice. Next slide, please. So just understand that, you know, if you were working in the world of Medicare, and I don't know how many people in the audience do work in the world of Medicare, but if you are working in Medicare or any other federal government program, you don't do this. I mean, you know that you cannot waive deductibles and co-pays of Medicare or Medicaid beneficiaries. This is a long-standing prohibition, and it's essentially viewed by the federal government as a form of a kickback or inducement to beneficiaries to encourage them to obtain services, and that then calls into question whether the services are actually, in fact, necessary. So you can read the slide for yourself. I've got a quote from the Department of Health and Human Services here that explains why, essentially, in a nutshell, why they think this practice is problematic. Next slide, please. And then, you should be aware that there are certain states out there, not the majority, certainly a minority of states, but there are states out there that expressly prohibit fee waivers also. I've put a Florida statute there. I put a Colorado statute. California, where I am, does not expressly prohibit this through legislation, but this is an issue that gets litigated by certain payers. There was a pretty well-known case that was brought by Aetna against some surgery centers, some out-of-network surgery centers several years ago, and it was primarily based on the surgery centers routinely waiving co-pays and deductibles, et cetera. There were some other practices that Aetna was investigating as well, relating to how the physicians who owned the surgery centers, how they were making referrals and things of that nature. But the main thing I want to emphasize here is that this case went to a jury. But very few cases go to juries. 99% of all lawsuits settle. This case didn't settle. It went to a jury, and the jury found in favor of Aetna and awarded Aetna $38 million in damages against the surgery center. And this is kind of a shocker to a lot of us in the industry because, this is a jury, people who are primarily have been patients or are themselves, and who probably would be the ones to benefit from these fee waivers. They're finding that this surgery center had committed fraud by its practice of routinely waiving patients' cost-sharing responsibility. Next slide, please. So there's a lot of guidance in this area, and it's not new. I mean, these are some old cases, one from 1991, another from 2000, both of these actually the Seventh Circuit. And, the first case, Kennedy, just real quickly, that is a situation where the provider was expressly agreeing with his patients that the patient would not have any financial responsibility for the provider's services, that the provider would look solely to insurance for reimbursement. And in that particular case, Cigna found that out and said, well, if the patients of our members don't have any, or our insureds don't have any financial responsibility, then neither should we. This insurance product is a indemnification policy. If the policyholder has no liability, has no injury, then there's nothing for us to indemnify. And the court agreed. A few years later, same court looked at a different case where they distinguished the earlier Kennedy case on the grounds that in this particular case, the hospital was not expressly agreeing with patients that the patients wouldn't have any liability. In fact, the hospital, to the contrary, was requiring patients to sign an agreement of financial liability. The only thing was the hospital was not aggressively pursuing collections. They weren't putting people in collections. They weren't hiring third-party collection agencies. They just were sort of letting people get by. And in this particular case, the court said that's okay. We're not going to let the insurance company, let them off of their obligation to pay claims, because the hospital in this particular case made good faith efforts to collect, just wasn't always able to collect. They weren't going so far as to put people in collections, things of that nature. So that was a very important distinction. Next slide, please. Most recently, there was a case in December of 2017, also involving Cigna. This was against a surgical hospital in Texas. And here, what was unique is that Cigna had actually put into its insurance policy exclusionary language on the issue of fee forgiving. The policy essentially said, if you're not required to pay your out-of-network, your out-of-pocket cost-sharing amounts, then coverage is excluded under this policy. And this was litigated, went all the way to the Fifth Circuit, and the Court of Appeal it agreed with Cigna that Cigna's interpretation of its own policy was not in bad faith, that it was not arbitrary. So the court didn't exactly go so far as to say that fee for giving is unlawful or is fraudulent or anything of that nature, but was willing to say that because Cigna's interpretation of its own policy was not done in bad faith, that in this particular case, Cigna was allowed to avoid paying the claims. Next slide, please. Okay, so let me wrap up by talking about financial hardship waivers, because this probably is the one safe way to engage in fee forgiving. And I don't mean that by like as a routine practice, but what I mean is there's always going to be a situation where you have a patient who simply cannot afford your services. They simply can't afford to pay the deductible and the co-insurance amounts. And that's, Medicare has an exception to its rule that, if there's true financial hardship, then it is okay to waive or discount co-pays and deductibles, and et cetera. But you have to document it. That's the main thing here, is that you have to have your patient submit a complete application for this financial assistance, or if you want to call it scholarship. But you've got to have a real application. There's got to be a real showing by the patient as to what their financial circumstances are, and if they qualify for this assistance, then it's okay to discount or waive the deductible and to reduce fees according to the program's set standards. Next slide, please. But if you're routinely doing this, if everybody who walks in through the door gets a scholarship, regardless of what their financial circumstances are, then that's a huge red flag, and that's the kind of thing that the insurance companies are looking for. And believe me when I tell you this, they will contact their members. They will send questionnaires. They will phone them up, and they will ask them about whether or not whether the member was ever required to pay any deductible or co-insurance, if they ever saw a invoice from the provider. The insurance companies, they continue to audit this issue, and it's a big deal for them. And by the way, I should say that you absolutely want to make sure you are invoicing patients, because even if you are collecting something up front, if you're not documenting that, then that's going to be, if you do get audited on this issue, then you could have trouble proving to the insurance company that you actually are, in fact, not fee forgiving or waiving co-pays. Okay, that's all I have. I'm going to turn it over to Paul. Thank you.
Thanks, John. Before I jump in, David, and change this slide, I'd like to sort of outline how I think about audits, both steps that can be taken, and then to hopefully prevent or avoid as many audits as possible, but then also how to plan for audits in the future, and then what to do when an audit request arises or is received for the first time. So I'll break it down into three buckets: things you can do, best practices to adopt to hopefully discourage audits or avoid as many as you can, then things to do as you start thinking about preparing for audits, which, whether you've received one yet or not, I think it's never too soon or too late to go in, review your process, and think about how to improve your process and your communication around audits. And then third, what to do when the audit has hit your door. What specific steps to take, how to take your overarching process with respect to audits and refine it and tailor it to each audit request that you receive. So David, jump, if you don't mind, into the next slide. And we'll talk first about efforts to minimize the risk of audits. Now, John correctly pointed out a handful of areas that are targeted by payers, including insufficient documentation. I think we've all been down that path probably a few times. Noncompliance with payer guidelines, building discrepancies, among others. I agree with John, too, that the emphasis really here should be on documentation. Hopefully you're providing the care and you're documenting that correctly. That will go a long way as you think about audits. So let me first of all say, if you haven't received audits yet, if you're only a private pay provider, and you just have been, frankly, fortunate thus far, I will tell you that you're going to receive them. Over the course of the last handful of years, these audits have truly become increasingly common, and many many providers have received more than their fair share of these already. So if you've been lucky thus far, then continue to rely on that luck and build some practices internally to help you and to put you in a position to respond adequately and well to these when they come. So backing up a step, before you think about audits, I think the things you can do to minimize the risks include things like providing the best quality care possible, measuring it in appropriate ways, and, of course, documenting that. Many of these audits can be triggered by poor outcomes, patient complaints, concerns raised by your own employees or referring physicians, medical directors. And so, the best way to avoid that bucket of audits is to not have issues in the care you provide to the greatest extent possible. Protocols can be helpful there, and other clinical guidance internally can be helpful there. And again, I think those are important things to do separate and apart from audits, but they certainly will also help you deal with audits. Second, strongly urge you to avoid some of the questionable practices that are identified. In addition to the waivers of copays and deductibles, some of the practices that, we sometimes see in this industry in particular around helping patients, once they've made the phone call to get into your program, they've identified your program and frankly, in many cases, paid for your program, they're sort of down to their last dollar. How do they travel to your program? Many mission-driven organizations and others who want to help these individuals in their time of need sometimes are quick to provide plane tickets, both for the patients and their loved ones. Sometimes there's a hotel room involved for the night before they enter treatment if they're traveling from a distance. All of those things really raise issues and can lead to the same kind of questions that John has already discussed in his first portion of the presentation. Encourage you to be extremely thoughtful about those and to really have a bias against doing those things. If you're going to do them, make sure they're covered in your policy. Your policies around providing discounts and scholarships, just to use a term that sometimes comes up in this context. Third, again, sort of to repeat the obvious here, which I guess I do all the time, pay attention to the coverage limits and the coverage guidelines issued by the payers, the commercial payers that you are dealing with, and follow those. You might, as John suggested, if you get into litigation, you certainly might have an argument with them about whether or not those policy directives are legitimate and enforceable. But again, the goal here is to prevent audits. So to the extent you can, be sure to comply with those. Those are updated, of course, by the payers on their websites and through other means frequently. So make sure someone in your organization is tracking those. And then fourth and finally, perhaps, which is segmented into the next slide, is be proactive. And to the extent you can, and we'll talk about peer reviews on the next page, but to the extent you can, please audit and review on claims to determine whether or not you are meeting, you and your providers are meeting the expectations that you have and that certainly the payers have for what their files will look like when they come to audit them. Next slide, David. So again, I believe in being proactive. I think it's important to review our claims. I am a big fan in smaller organizations of peer audits. So if you have two facilities, for example, at one quarter perhaps, or as frequently as you can, having the billers from one that are responsible for one of your two facilities look at the work of the other facility and vice versa, I think is a great practice to adopt as you remain a smaller organization, as you think about growth. Now, I'm quick to say, though, that those peer audits are only as good as the education and the training provided to those individuals. So be sure that you have a knowledgeable person check audits, look for it not flagged that should not have been, and when you see those, be sure to follow up and provide education to those individuals so that the effectiveness of those peer audits will increase over time. And that's certainly a practice that benefits both you and those engaged in the billing exercises. So something that I think is really important if you're not able to go in and truly have a compliance department that looks at audits in a more removed way, if you will. The other is that you should have policies and procedures that speak to billing, that speak to a lot of issues and concerns, but certainly those around billing, and those as clear as possible. And again, providing education around those is important. I sort of have a mantra in this area that I wish I could come up with an acronym for, but it's something like, and I'm going to say these things a lot, probably: process, plan, education, policies and procedures, remediate, and deadlines. Those are words that I think are all really important as you think about preparing to receive and receiving claims. Maybe they're peppered. I'm not sure if that one's available. I know Pepper Reports have already taken that, but in any event, those are certainly concepts that I think are important. So moving on to the next slide, David. Once you have an overall plan in place, which is an important first step, conversations internally, which are never too soon to have, about what are we going to do when we get audited, who's going to take the lead, who are the logical people to involve, sort out some of those points of confusion before you start getting audits, because, in my experience, once you start getting audits, it means that you've reached either a relevant size to Payors, or you're sort of on the radar. And so it's like once you get your first one, the number you get, is likely to increase, over a relatively short period of time. So if you haven't had a chance to sit down with the appropriate team, make sure you do that, and ideally you can do that before your first audit shows up, to get a game plan, to get how you're going to handle the resources you have available to devote to audits when they arise, who should be involved, what kind of evaluation are you going to do of the audits up front. Do you have a shared understanding of how to evaluate whether the audit request is just normal course as opposed to maybe one that's unusual, or one that has extrapolated results suggesting that perhaps it's not an ordinary course? Do you have concerns around your billing processes? And if you do, now is not too late to start addressing those. But certainly, if you have those concerns, then think about how you're going to approach those in the process, because those are concerns that will likely be identified by the outside payer, and so you're going to need to respond to those. And then don't be scared, please, of involving both lawyers and outside experts. Those people are extremely helpful, and in my experience, no lawyer has ever been anxious to take over an audit response. But also in my experience, I've seen a range of lawyers be extremely helpful to evaluating audit requests when they come in a very fair and sort of objective way. And I think as a member of the team, certainly a lawyer who is up to speed on your business or who is embedded within your business is a great partner to have. Other logical members of that team that on the next page, of course, include your compliance officer, which hopefully you have, and we're going to talk about compliance a bit. Perhaps an internal audit manager, if you have such a function. And if you don't have that function, the person who performs those roles for you internally. So you're sort of closest approximation of the internal auditor. That may be the person who actually bills and files the claims, but regardless, hands on them, identify them, let them know they're going to have a role in this process, and that their specific role for each audit received will be determined by the team, and ideally by a team leader, as those audits start to come in. So where we are now, and it's sort of the buckets, we're sort of heading into the third bucket, which is what do you do when you get an audit? You've been expecting it, you have the team around, hopefully you have good policies and procedure and some common language about how you're going to respond to the audit. So when the audit comes in, the audit request comes in, it's really important to immediately pay attention to it and to be thoughtful about it. How you proceed to respond to that audit will be determined, or should be determined in my view, based on a number of factors. Is it an audit that you're concerned about? Does it seem unusual as opposed to routine? As I said before, are the results extrapolated? Are hundreds of claims involved, thousands of claims, dozens, or one or two? Those are relevant considerations. Is it an area in your billing process that you have reasonable concerns about for whatever reason? Does it feel like a weak area? All of those things suggest that additional steps need to be taken by you before you send the paperwork back to the payer, the person requesting the audit. Among those things that I would encourage you to consider are, do we need, so I think you always need to look at the claims that have been requested before you send them back. But then the question is, if it's 1,000 claims, do you need to look at every single one of them? Do you need to look at a sample? And if you're going to look at a sample, should it be a statistically significant sample? The results of that review could potentially bind you with the payer and other third parties, which is not always either avoidable or a bad thing, but it's something that should be done thoughtfully. Or do you review a smaller subset and then make a decision? Do we think we have a problem? And if we think we have a problem, we'll reserve the decision about whether to review all claims or a statistically significant sample of claims once we determine whether or not, based on our first look, we think we may have a problem. Again, so these things require both judgment and experience, something that if you don't have yet, you will certainly develop as audits come in. And it's also certainly something that you can rely on your outside advisors to help you with, assuming that they also have experience in this area. But there are no clear answers here, I would suggest to you. A lot of it is based on feel and experience. A lot of it is based on the nature of the audit request. But it's an important analysis to go through as you're considering how to respond to the claim the audit request, because these should all be taken seriously, and they could lead to trouble, including things like, as John referenced above, a suspension of payments, a claim to recoup payments, an obligation to refund overpayments, all of things that can have disproportionate impacts on smaller organizations in particular, including those that might not be able to withstand the cash flow issues that result from having, a payer tell you they aren't going to pay you for a period of time until your dispute is settled, and then having to go to court to argue that they're wrong to have done that. All of that is very expensive and is something to be avoided, which is one reason I suggest here, lessons learned. Always make sure you involve somebody from finance, whether that's your chief financial officer, or someone serving a similar role, if you believe that either payments are going to be stopped or that you're going to owe a refund. It's never too early to involve the financial people. They need to know about it, and it's important. Then moving on, let's see to the next slide. Then now you have a plan. The plan that you're going to come up with, this is now at the specific audit request level. And again, it speaks to whether this particular audit request deserves a full review, a statistically significant review, or a sample review. It raises questions like, based on what you find on your initial look, do you need to look at other payers? Might this be a systematic issue that you can get ahead of? And I hope it is. When problems arise, the ability to get ahead of those problems and to take remedial steps before those other payers become aware is often extremely important, both to the relationship, but also as to the remedies they might seek. It's less likely that they're going to stop payments to you or seek to impose some other draconian position on you if you've gone to them in advance, identified the problem, and then know that you're going to work with them. And so, again, that's a reason to be thoughtful, and it's another consideration when you get an audit. All of that is to say, I clearly have a bias underlying for responding. Not everyone in the world agrees with me, but I think that is sort of a critically important step, especially if you have a concern that the audit is unusual in any way. I just couldn't emphasize it enough. Now, through all of this, as you're going through and hurrying and rushing to consider the nature of or the request, there are other key things to keep in mind. As I said before, my mantra: keep in mind what deadlines you're working against. Be thoughtful about the amount of time it's going to take you to pull together all of the relevant information, even if that might involve going to different facilities and pulling that out of those disparate facilities. It might involve having to get the right experts lined up to review. It might involve getting another lawyer involved or an accountant or outside auditors. So depending on what kind of audit response obligation you face, the time it will take to pull together all of that information, review it, prepare it, understand what kind of issue you have, if any, going forward, are all things that could take time. And again, you don't want to miss the deadline. So those things need to be done post-haste. David, on the next slide, you'll see that I continue to talk about those things. If you get into the claim request and you realize, wait, I don't think we can do this within the time period that we've been given, communicate that back. It's not an unusual or unreasonable thing to go back to the payer and to request more time. I would suggest you do that in writing. In fact, I would suggest all of your communications be done in writing in this context, because you are, in fact, entering into an adverse relationship with your payer. The question of how adverse it's going to become remains an open one, but it's adverse because they've sent you an audit request, which means they're questioning, probably, your claims and the sufficiency of the documentation that supports or not your claims. So it's important to communicate with them in writing. It's important to involve counsel. It is important internally to watch how you, while I certainly think it's incredibly important to be transparent with your team, it's also incredible to recognize that you are adverse to your payer at this point. And so sending long, thoughtful, sometimes angry emails internally discovered subsequently or rarely in your best interests. And my experience with email, suggests strongly that it's something to be very careful with. So think about the fact that you could be involved in a claim situation in litigation, and make sure that you respond. And you want to respond in writing. You want to provide full documentation that supports the claim that you've made to the payer. And if you're able to both share audit findings in the right circumstances, and also share with the payer in your cover letter any corrective actions you took as a result of their audit request, those things can be very helpful, can demonstrate good faith, and can also demonstrate best practices. And then finally, learning from your process, sitting down afterwards, making sure that you talk to the team about the process and improving your process on an ongoing basis, I think, is also critically important. So, John, with that, I've received a couple of questions for you. Perhaps we have time for one. Let's see. So here's one, John. We don't provide services, and it says yet, to federal beneficiaries there, and I guess they're talking about Medicare and Medicaid. So isn't our risk of audits in claims on the waiver of copays and deductibles pretty small? And essentially, can we take the risk of doing that, given that our mission is to provide care to a very needy population? So what's the risk that they're going to get an audit request on that? And given their mission, is it something they should be doing? Or could do anyway with a low risk?
Right. Okay. The risk is not as high as it would be in a federal program where we have very express prohibitions by Medicare. And certainly, I have to tailor this question with maybe depends on what state you're in, because there are certainly states like Florida that have legislation on the books on this. But I mean, as just a practical matter, the insurance companies, they do look for this issue, and if you're doing it, if it's a routine practice, then I think the risk is high that you are at some point going to be audited on the issue, and that could lead to the insurance companies stopping claims payment, and or if they don't stop claims payment altogether, they will say going forward they need to see evidence of collections going forward, and they will seek an overpayment for prior claims. I just don't think it's realistic to say that in this environment that if you're only dealing with commercial payers and your mission is to provide services to the needy, that somehow you don't have risk. I mean, if your population truly is needy, then you need to document that. Maybe it is that you have every single patient needs financial assistance, and you can document that, and maybe that's the case. But in my experience, I'm seeing too many of my clients who are just making this routine practice, or they're not documenting it properly, and they're running into problems with this issue. So I do think there is risk here.
Yeah, I agree. I think documentation and having a clear policy around financial hardships is important, as you've suggested. So, David, I think with that, we probably should stop here. Let me turn it back over to you.
This concludes today's webinar. A reminder that in 2 to 3 business days, Epstein, Becker, Green will email registrants a link to access a recording of the presentation and PowerPoint materials. This webinar series is a collaboration between Epstein, Becker, Green, Nelson Hardiman, and the Behavioral Health Association of Providers. We hope you'll join us for the next installment on Thursday, November 1st at 12 p.m. Eastern Standard Time. Presenters will discuss the changing regulatory landscape around medication-assisted treatment. For more information and to register, please visit www.ebglaw.com/events. Thank you for attending.